So, so we introduced ourselves. So we're both nurses with an extensive background in cancer support and nursing. We work part-time across the two information centres. One's in Warwick at the Aylesford unit and the other one's at Stratford Hospital in Rigby, at the Rigby unit, sorry. So first we wanted to touch on the changing story of cancer, really. In the 1970s, if you were given a cancer diagnosis, it was a very poor survival rate of less than a year quite often. I remember when I started my nursing in the late 80s that people with a cancer diagnosis, it was usually very palliative, and their care was with palliative care. But due to advances in treatment and further research, 50% of cancer patients are now living over 10 years. And the figures for 2025 are there are 3.5 million people living with cancer. And the predictions are that by 2040, there's going to be over 5 million people living with cancer. Each year, there's around 400,000 people in the UK diagnosed with cancer, affecting 1 in 2 of us. Some cancers have better outcome than others, but treatments are changing all the time, and immunotherapy is changing this picture even further, really, I would say. And, you know, monthly new treatments are coming on all the time. For Coventry and Warwickshire, our statistics show that by 2030, there's likely to be 48,000 people in our area living with and beyond cancer. So there's a lot of people out there living with this disease. For various reasons, you know, an ageing population and people not living well generally, often people have got multiple conditions as well as their cancer. So people can be living with obesity, diabetes, chronic heart disease, kidney disease, hypertension. So it's not uncommon for people with cancer to have other comorbidities. And that's why it's really important that we have a personalised care for looking after cancer patients, because they're not all coping with the same issues. I think it's fair to say that not everyone is living well with cancer. And there's 4 factors that contribute to this. 1 in 4 patients have consequences of their treatment. 1 in 2 have other comorbidities that we've just discussed. And 37% of patients are likely to be unemployed, more than the general population. And sadly, 1 in 5 people living with cancer suffer with loneliness as a result of their cancer diagnosis. I just wanted to ask a question. We can't see the chat, but hopefully Michael will be able to tell us if you can put some answers in the chat. We wanted to ask, what consequences of cancer treatment have you either seen or experienced yourself? If you could just write it in the chat, that would.
So the people that are listening, could they put some comments about self-experience? I think we need to allow them time to put it in, and also as a delay when it appears in the chat. So, so we'll let that happen as we go, and I'll tell you if something happens for you to know.
Okay. So should we start to talk about some of the consequences we've got then, or do you want to give people a bit more time? So should we go on to?
Yeah, no, there's one coming from.
Okay.
Yeah, oh yes, there's one coming from MW. Not personal experience, but depression and hair loss.
Yeah, absolutely, definitely. Those 2. Depression's a big thing. I think that's often underestimated.
Am I allowed to add something to that?
Yeah, of course, please do.
That applied to me as well. I was really quite annoyed about the hair loss that I had. Anyway, we'll talk more about that later.
Yeah. Anyone else put anything else in?
Mr. Flaxman said, induced colitis from immunotherapy, hair loss from chemo, pains from radiotherapy. So the matching three there, I think, they're immunotherapy, chemo, and radiotherapy.
Absolutely. And so we'll have a look at some of the lists that we've got. So it's not exhaustive, but here are some of the physical, we'll go through some of the physical consequences. So pain is one of the consequences of treatment, and that can be at the time or afterwards, a long time afterwards. Persistent hair loss. Heart disease can be a consequence of treatment, particularly some chemotherapies are toxic to the heart. Nausea and vomiting can be at the time when you're having your treatment, but long-term urine and bowel incontinence, changing in your bowel habits can be a long-term consequence of treatment. Sexual difficulties can also be a consequence of treatment that is often underreported for men and women. Sorry, I'll just have a drink. Peripheral neuropathy, lymphedema and osteoporosis, breathing difficulties, like I'm having, swallowing of speech problems, weight loss, or weight gain, and that can affect your body image and how you feel about yourself. The mental health issues can be depression, anxiety, the impact of the diagnosis, and uncertainties about the future and worries about the future. And at the bottom, we've got social and financial difficulties. Not being able to work can affect you socially and financially. Some people get full pay when they're off having their cancer treatment. Some people will get a week's pay when they're having their treatment, so can really affect them financially. And fatigue affects 90% of our cancer patients. But we're going to look at that.
Can I give you a couple from the chat as well?
Yeah,
because there are consequences. Okay, there is the consequences of induced colitis, immunotherapy, and chemo, pains from radiotherapy. But then on top of that, it's been mentioned about a cold caps improves hair loss situation, which it does.
Yes, it does.
Okay, then somebody else is also a breast screening about whether that should actually be extended past 70. Would that increase life expectancy?
Of breast screening? I don't know, because screening is decided nationally and they're looking at outcomes for the whole population. So that would be a question as a more of a national thing, and they look at the statistics and the number of people being diagnosed through screening. But I think that they decide the cut-off points, the starts and the ends, depending on a whole population figures.
I think the other thing to say with something like breast cancer is that we know that it's more prevalent as you get older, as we get older in age, and therefore it may be something that is looked at in the future.
Trying to stop coughing. So the
have you got a drink of water there or something?
Yeah, I've just had one. Yeah.
Have you?
The physical late effects of cancer treatment. These are some of the physical late effects, and they can last for years, or they could have a delayed onset. So some of the immunotherapy consequences of treatment, like the colitis, can happen sometime after treatment. They're not necessarily whilst you're having treatment. And also, I think there's an expectation that when you finished your treatment, that you'll be back to normal, and that it's all over, done with now. You look the same as you did before. And they forget that you can often be dealing with these long-term effects. I think there's a barrier to reporting the consequences of treatment. And this can be a lack of information or awareness that that something can be done about it. And some people feel that they don't want to raise the problem because they're grateful to be alive, really, and they don't want to bother the healthcare professionals with these issues. Symptoms can appear months or years after treatment, and they're often not linked back to their cancer. And patients and healthcare professionals don't necessarily know there's anything that can be done to manage these symptoms. And sometimes a barrier to reporting them is the embarrassment. If they're of a personal, sexual or bowel problems, people are not always very keen to come forward and complain or raise the issue that they've got this concern. I think if someone does are brave enough to mention that they've got issues and consequences of treatment, it's important to listen to what they're saying. Acknowledge that this is really an issue that something could be done about or should be done about it. We don't always have to fix things straight away, but just spending some time listening and talking through how this is affecting their daily life can be really supportive and helpful. And you don't have to have all the answers straight away. But when you do have that information, I think use the resources, signposts, get advice for them, because there is something that can be done for these consequences to help. I'm going to hand you over to Ginny now.
So we're learning more and more about delayed effects, and as time goes on, more statistics and research is being done. Cancer survivors can have needs that persist up to 10 years after diagnosis that are not addressed because, as Lisa said, they're not always linked back. In this order, the most common are physical, financial, educational, and personal control. And with education, with younger people, there can be educational needs often where they're missing out on school or university time. Personal control includes sexual and mental health issues. So it covers a lot of sort of issues that patients are having, really. Each patient on average experiences 3 unmet needs. Men are more likely to report physical and personal control. Women are more likely to report financial, emotional, and social problems. With new treatments like immunotherapy and targeted treatments, we're still learning about long-term effects. So again, these are likely to be movable and can vary as time goes on. And I think the other thing to say is it's really important that, as Lisa said, we listen to the patients, because we do know that sometimes the actual symptoms that patients get, maybe even delayed, can be worse than the treatment at the time, particularly when they expect to be moving on. So how do we identify what's important to the patient? Don't ask me what's the matter, ask me what matters to me. We use the Holistic Needs Assessment, or the H&A, as a tool to identify their current issues and concerns. A local focus group working with professionals wanted the name of H&A changing to Personalised Needs Assessment, or PNA. So the trust have moved to this, and it was felt that it made more sense to the patient in terms of what was being asked. It's a national tool. It's given to patients at diagnosis and at the end of their treatment, and sometimes it can be used throughout the treatment. It can be done on paper and electronically. The electronic version has increased response rates and seems to be the preferred method of completion. Once completed, there's a discussion with a healthcare professional, and a care plan is generated together. And then this care plan can be shared with the patient and their GP electronically. So this is an example of the paper version, and patients basically tick off their issues and rate their level of concern from 1 to 10. Some patients might tick a lot of concerns, and if this is the case, it might be necessary to just identify the top 3 or 4 and concentrate on these in order to allow time to actually look at that concern in enough detail. And there might be a need to revisit again if there are other concerns that don't actually get addressed in the discussion. But very often you can find that they kind of tie in together. So what does it look like in practice? Having the conversation and asking the patients and making sure that they know how to do the assessment tool. There's no point in completing it if they're not, using it properly. Sharing information, patient completing the H&A. Having their needs assessed, which is spending time discussing identified concerns with the patients. Developing a care plan together, and that's done in conjunction with the patient. It's their care plan. Signposting for support and giving of information, and then sharing a copy with the patient and the GP electronically. I'm going to hand you back to Lisa again, if you can.
Yeah, I'll stop coughing now. So, follow-up for cancer treatments changing, and some cancer sites are using personalised stratified follow-up. There's 2 options for patients. There's professional-led for patients with more complex issues, and then for those patients with low risk of recurrence, there's personalised stratified follow-up. And this is having a treatment, an appointment at the end of your treatment where you're signposted to self-managed. You're advised what to look out for. You still get your planned tests and everything, but if you've got any problems, you have direct access back into the system. This is aimed to help patients report symptoms or changes when they happen rather than waiting for the next appointment. So before it used to be that you would have an appointment every 12 months and, as you were going along after you'd finished your treatment, but you might have some symptoms at 9 or 10 months, but then you would wait till your next appointment in a couple of months' time. Whereas this is hoped that people don't wait and they do come forward when they have issues, when they know what they're looking for. Following this end of treatment appointment, this is written into a treatment summary, and a copy of this is sent to the patient and their GP. And this sort of lists the red flags, what to look out for, lists what treatment you've had, and can be used, if you had to report what treatment you have, say, to get travel insurance and things like that. And the idea of this sort of follow-up is empowering the patients to take a more active role in their self-management. It's tailored to their needs and helps them move on with their lives. We said we'd have a look at fatigue because it's such a common symptom for cancer patients. So fatigue is persistent, distressing, subjective sense of tiredness, not usually proportional to recent activities, and it interferes with your normal, usual functioning. If we have a busy weekend and we're just tired on a Monday, then, by Tuesday we're feeling fine again. But fatigue's not like that. It's not related to your activity. It's just more of a really oppressive, constant tiredness. It can be cancer or treatment related. It affects people differently and can last months or years in some people. And 90% of people, as we've said before, with cancer report feeling fatigued at some point. And the expectations of others often are, well, you finished your treatment, it was finished a long time ago, you look like you're back to normal. Why can't you do what you used to do, and why are you not the same as you were? And to explain the fatigue and why it's particularly difficult and can last a long time, is the fatigue cycle. So you've got your cancer-related fatigue, and when you're feeling fatigued and tired, you rest excessively. So you rest for quite a long time. whilst you're resting, you're physically deconditioning. And then that deconditioning leads to some muscle wasting. But when you're having a good day and you feel like you're right, I can do things today, I'm going to do a good day, you overdo it and do too much. And then the next few days, you're really absolutely exhausted. But this is accumulating fatigue, because then on your next day, you're not quite as good as you were on your last good day. And then you do too much, and then you have even more days of rest. So this then increases the need for more rest. And then you just keep going around in this vicious circle, really, with your fatigue. So we wanted to look at some ways of managing your fatigue better, really. And it's important, a good way to tackle fatigue is do something gentle and some sort of exercise every day. So rather than doing lots of exercise, just a little gentle walk, maybe each day, and you can increase the distance that you walk. Even if you only go to the garden gate and back to begin with, you can start to increase this. This will help you manage your fatigue rather than resting for long periods. Keeping a fatigue diary can be really helpful, and look at when you are more fatigued, because sometimes people will say, I'm fatigued all the time, I just feel tired all the time. But actually, when they do a diary and they look at it, they're not tired all the time. They might be tired in an afternoon or every afternoon. So actually keeping a diary can give you a bit more of focus of when your tired times are. And I think planning and prioritising what you can do and what someone else can do for you is a really important way of not overdoing it. So you can look at things that you can give to someone else, like maybe picking children up from school, or someone else doing your ironing, or someone else doing your cleaning for you, and that you do the nice pleasurable things like going out for lunch or meeting a friend for coffee, something like that, so that you're not exhausting yourself trying to cram too many things into your day. And then you don't get the exhaustion for the next few days afterwards, because you're balancing things out, so it's not all or nothing. It's like a savings account, really, whereas if you spend it all on Monday, you've got nothing for the rest of the week, whereas if you just spend a little bit each day, you can get through the week and it's more enjoyable, and your fatigue doesn't get worse. Eating well and maintaining a healthy weight will also help with your fatigue management. Keeping a normal sleep routine can be really helpful as well. So going to bed at the same time each night, not having devices on till late at night, using a nice, cool, dark bedroom, all the things that help to promote your sleep, and relaxing before you go to bed, not having caffeine too late, all those things that can promote good sleep. Using relaxation techniques and complementary therapy can also help you with your managing your fatigue. And I think if you've got a busy mind and you're not resting and sleeping well, some counselling or support groups can just help you mentally adjust to that. And then I think it's important, if you're trying to go back to work, to talk to your employer about your work patterns. If you've kept your fatigue diary and found out when you're more fatigued, you might want to just work mornings or work just afternoons or have shorter days. So, work with your employees to look at phased return or reducing your hours at work. And I think it's quite important to mention the benefits of physical activity. There's evidence to demonstrate that being physically active can help you manage and prevent consequences of treatment. It can reduce developing other comorbidities such as obesity or diabetes, for example. And the evidence is growing to demonstrate that exercise can reduce disease progression and reduce the risk of recurrence, which are really important things when you've had a cancer diagnosis. So I think exercise is very important to help people live with their cancer. And locally, our options are We have exercise on referral with Everyone Active Warwickshire. This is formerly what Fitter Futures was. We have yoga for our cancer patients who've completed their treatment, which is gentle yoga specifically designed for cancer patients. And that's free for the first 4 sessions. We've got some information on walking in Warwickshire and walks in Warwickshire. There's rambling clubs, walking football and walking netball. 5K Your Way, which is cancer patients doing 5K, moving for 5K, and that's in Stratford. And then the hospices offer programmes for exercise for palliative patients as well.
So looking at the local support available, we have Macmillan Centres in Stratford, Warwick, Coventry and Nuneaton, and these can be found in each hospital where there's patient footfall. So they're easy to find basically. There's a psychology service where patients who see cancer patients and sometimes family members. There are a number of support groups locally, including the ABC Bowel Cancer Support Group, Secondary Breast Cancer Group, Prostate Cancer, and coming soon, a gynae support group. There are national support groups on top of all this, but these are the local ones. Hospices, we have Myton and Shakespeare in this area, both offer the Living Well programmes and home care support. We do a Hope course here in Stratford. It's Help Overcome Problems Effectively, and it's a 2-day course for patients who have completed treatment, offering a tailored support in order to get back to living well. So it's prescriptive in one sense, but it also is guided by some of the patients and what they want from it. We have Look Good, Feel Better charity. This is for ladies monthly. We have volunteer beauticians who offer advice and expertise with skincare and applying makeup. And there's also one for men starting in September, and this offers skincare again, diet, exercise advice, and both have gift bags with products for them to take away, which are really lovely. So local financial support, we refer patients to our local Macmillan CAB for expert advice. There's a selection of work-based support booklets from Macmillan, and some of them we have out in the centres, but there are others. And a designated work helpline, plus help available at work through their line managers and HR. So it's important to find out what support you've got at work, what support is around. We help people with blue badge applications here. They're done online, and so sometimes patients find it much easier to come along, and we can upload all of the documents and unnecessary paperwork to go with their applications. Macmillan offer it, well, there's free will writing services available. We signpost to Macmillan, but there are other charities which offer this service. And we just put up that Macmillan grants are no longer available because they've been around for quite a long time, but at the moment they're no longer offered. So just to make people aware that that's a change. So we have a local complementary therapy offer, and basically we have complementary therapy provided by the Shakespeare Hospice and done here at the Rigby Centre in Stratford for cancer patients receiving treatment to help with symptom control. It's a pilot and it's taking place over 12 months and will be for review in February 2026, next year. There are 3 free treatments available to patients. The sort of treatments that we offer include Reiki, aroma sticks, reflexology, massage, relaxation techniques and mindfulness practices, and even group therapies we're looking at as well. So the complementary therapist has got lots of experience, and she will ring the patient and have a discussion about what they want and talk to them about what she might recommend. And we've had some very positive feedback so far, which is great. We do have a waiting list, but it'll be good to see at the end of the pilot, just to see, how much use it's been and, how much people enjoyed it and found it to be effective for them. So we'll see. Watch this space.
What's our role in the Macmillan Information Centres? It's to listen to what patients and their families want and need. It's to offer an opportunity to talk and some time out, really. We've got a little bit more time than some of the nursing and medical staff, so it's an opportunity for them to come and offload to us if they need to. We signpost to the appropriate services that we've discussed and more, really, than we've listed. And we make referrals for support to different services. We also support staff as well, and they come and talk to us, and this is a safe place for them, as well as for us providing them with information to help them support their patients. We provide the HOPE course that Ginny mentioned, and we support the complementary therapy service and the Look Good, Feel Better. And we talk about our service to raise awareness in the Trust. We are starting to get feedback from users of the service, and we're looking at ways to improve our offer and continue to evolve as a service. We're both fairly new in post. I'm coming up to 2 years and Ginny is about 18 months. So we are looking at how we're getting on, really, and what else we can offer. Our take-home messages today are: there is an ever-growing number of patients living with cancer. Not everyone is living well or reporting their consequences of treatment. There is support to help them. We need to listen to people's concerns, complete their personalised needs assessment using the holistic needs tool, and try and act on those things. Refer patients to us at Macmillan Information or seek advice or support for them. There are end-of-treatment clinics supporting patients with self-management. And really, we want to empower patients and encourage them to adopt self-care techniques and, of course, to exercise, as we've said. And if you've got any questions.
Okay. Well, there's certainly a couple of questions and statements in the chat. So can I ask Mike Wells to ask his, I think, 2 questions? Would that be okay to start with?
I think it was me rather than Mike Wells.
There's too many mics on this call, isn't it? Always is a problem, I seem to remember. Sorry. Yes, Mr. Flaxman, my apologies.
Thank you very much. Mike Flaxman, Public Governor, Stratford West and all that stuff. I had a couple of questions which I put in the chat about the link between Macmillan and the hospices, how well that works. And my other question is slightly off the wall. I'm really impressed with what you're offering. I think the service sounds great for patients that are referred to you. But my question really is if you take the QEH in Birmingham, they treat cancers that we don't in Warwick, but Warwickshire residents can be referred to them. And at the end of their treatment, QEH seem to refer people directly to hospices. And they, I think, might then miss out on the services that you're providing. And I just wondered how you might think about how to pick those people up as well. So that's my question, really. So just to try and make it comprehensive for Warwickshire residents who aren't necessarily or haven't been treated for cancer in our hospitals.
I think your first part of the question was, do we link in, how the Trust link in with the hospices? And we have got good working relationships with both the hospices. With the Shakespeare Hospice, their Living Well project for patients that are living well, we go and do a talk on week 1 for the hospice, and some of the support groups are held at the hospice. The secondary breast cancer support groups held there at the Shakespeare. So we're getting to know the staff at the Shakespeare Hospice. Equally, we did a pilot with Myton Hospice with some complementary therapy, and we got to meet some of the staff there. And we're referring patients to them, and they ring us as well. So it is kind of working quite well both ways. I think the patients that are treated out of area, they're more difficult to reach, aren't they? We've got a New to Cancer, which is an online 2-hour session where any patients that are diagnosed with cancer can join, and they're invited to join. We've got posters and different things advertising that, where we talk about the local information centres. But I think that's an area that we could try and look at addressing, really, I think.
And I think you mentioned about raising our profile as well. We need to get out. We're limited by the amount of hours we're here, but we're aiming to get out and about to some of the areas where, not necessarily the cancer areas, but areas where people are coming in for diagnostic reasons, and so that we're just there, or that people can see that we exist, and we hope that will help.
And we hope the specialist nurses that might be, when the patient gets their diagnosis locally, are giving our information. The cancer navigators are giving that information, so that patients know we're available locally.
You can have a diagnosis locally, but then it'd be immediately transferred to a specialist hospital for treatment outside of Warwickshire. So I think there's a bit of a gap there, in that patients finishing treatment elsewhere aren't necessarily being able to benefit from the service you're offering. So perhaps you could have a look into that one. That would be helpful. I know you're very busy.
Well, I think
it does seem to me to be a small gap.
Yeah. And I spoke to a social prescriber yesterday who's working at one of the GPs locally, and she was asking some questions about a patient who is actually going to be treated at Coventry, not South Warwickshire. But we rang her and got in touch with her. So I think, we're getting into primary care. I think you just have to spread it to whatever patient, wherever a person touches base, that they know that we're here, really, isn't it?
Okay. The only other point I made was that QEH Birmingham has got a direct phone line for patients to phone in and discuss their side effects, and they're then offered some sort of palliative treatment or advice on how to deal with it. Do we provide the same sort of thing?
The hospices do have
only the hospices, not the hospital itself.
The hospital have the acute oncology service if someone's unwell, that they can ring a direct number, and all
I see. That's fine then. Okay.
Yeah.
It is there. Thanks very much for that. It's a really interesting presentation. Thank you.
Thank you, Mike.
Okay, Mike Wells, the other Michael, do you want to make your point?
Yeah, just switch my camera on.
I know.
We've decided to have a moment. It's not switching on, but
there we are.
Right.
Health on the screen. Excellent presentation. Thank you very much. You talked about the 2 hospices. I was interested to know whether you actually have any dealings with Shipston Home Nursing as well, who do palliative care in people's homes.
And we know of them, and we know they work. The hospice at home, they work together, don't they? The 2 hospices and Shipston Nursing. But we don't tend to have. We know they're there, and we refer patients to them if they're in that area. But I would say it's a relationship we could work on, isn't it?
Yeah, it's another area that.
No, if you need any introductions, I could sort those out for you.
Okay, that's lovely. Thank you.
The chief exec really well. So.
Okay. Yeah. Good. That'd be lovely. Yeah.
Okay. Thank you, Michael Wells.
Okay,
right. We go to the people with their hands up, the electronic hands up. I've got Callie from over there in Rugby, I think it is.
Yes, it is. Yes. Hello, I'm Callie Harrison I'm the public governor for Rugby and North Warks. Right. My question is, I know your presentation covered people at different stages with their cancers, because recurrent, early onset, I suppose it covered everything and what services are available. I just want to ask 2 questions. This personal needs assessment, is that provided by all hospitals locally? Because I've seen the one that Coventry gives to people, and it wasn't. I don't think, because I had a look at what you were presenting, and it was a bit different. And also the other observation would be, people have different symptoms depending what cancers they've got. Like if you have lung cancer, you struggle to breathe. It's different problems. So I just wonder, what's the case with these personal needs assessments? Is it all hospitals gives these to cancer patients, and do you think it's pretty well designed? Because and on many occasions, carers have to fill in these forms if the patient is unwell or cannot go ahead and fill in the form. Basically, that's my question. So, and I'll ask the other one.
So have you finished? Is that your end of
Yeah,
your questions?
I just had another one, but I just haven't.
I'll tell you what.
had-
Put your hand down. See if
Okay.
somebody. Put your hand down. See if anybody else wants to ask a question. You can put your hand up again.
Okay.
Be reminded like at school. And I've got a school. I've got my schoolmaster's picture on there for you.
Definitely.
Okay. So,
I have one
anybody
more
else got a
question,
question?
but that's all right. I get this answer first. Sorry.
Just talking about the personalised needs assessments, and that using the HNAs, it is a national agenda. It might be that different trusts in different areas use them in different ways, but they are being used. And you talked about sort of different symptoms, and that's why they're so good. They are personalised, they are individual. If you look at the electronic one, the Macmillan HNA, you'll see that it does have various symptoms, but it covers lots of physical, emotional, spiritual concerns. So it tries to cover everything. So it should be that it does cover all of the symptoms that are talked about. And some of the questions are open so that you can say, what symptoms you're experiencing.
Okay.
It's just a good way of covering and giving that patient time. One of the most important thing is to sit down with someone and actually allow them to have time. And you're right, sometimes it might be a carer or somebody that's with them that is helping them to do it or filling it in, but it is for the patients, obviously.
I do understand your point of view, but sometimes when a person doesn't feel well, they don't want to fill in a form, basically. So that's why I said sometimes the carer needs to do that and try to answer your questions, and they don't feel motivated, as you mentioned, fatigue or being despondent, or whatever the case is, but obviously they don't feel that well to fill in the questionnaire. That's why I was asking, and I experienced it, that's all. So
yeah, and if that's the case, it's not set in stone that you absolutely have to do it on this day. It might be that there's another time, or Lisa was talking about fatigue earlier, and there are certain times when a person might be feeling more themselves or better or more able to have a discussion. It's there to help the patient, not to be arduous, difficult for them. So
and see what additional support you can provide to someone, because obviously it's so many different aspects that you have to deal with as a cancer patient in your life. So that's
most of the healthcare professions will be aware of that, and they'll work with the patient. There's no point in doing it if they're not able to do it. It's best to get them when they're they feel able. We'll get
thank you,
out.
I just have one more question.
Oh
Sorry.
my God, question producing. Carry on then.
Yeah. I just wanted to know if you think that cancer patients with comorbidities, they get the right support, and how we can improve service too, because loads of cancer patients may also have cardiac and whatever heart issues. They they have to deal with loads of things. They take loads of different medicines, and how we can facilitate all that. Is that the oncologist who needs to do that? Is it a group of clinicians? But comorbidities is a big issue for cancer patients. That's my question. Thank you.
I think the comorbidities, like we've said, we acknowledge that, you know, patients have got more than one problem. And sometimes it's the GP that's coordinating that care for the patient because they see them. But what we were talking about with asking patients what their needs were and what their issues were, that's part of making things personalised for them and not treating them as though you've got this cancer, you'll have this treatment and we'll do this for you, because you've got to adapt things because not everyone's the same, are they? So I think it's a combination with the medical staff at the hospital looking after the patient and the GP to coordinate all of their medication and the management of all the comorbidities.
Yeah.
And I think
Thank
it's just acknowledging them, really, that it's not the same for everybody.
And it does highlight the importance of communication between the healthcare professionals as well.
Exactly. I mentioned these issues because obviously community support across Warwickshire is provided by the staff that are directly employed by our trust. But sometimes the referrals to these community teams from Coventry is not always great, and I experienced all that. So communications are very important. That's all.
Yeah.
Okay, right. Thank you for that. Is there anybody else that would like to raise a hand to ask a question? I'm not an expert at looking for these raised hands, so I'll do a little search
I
there.
can't see any.
Right, I can't see any. So, well, if that's the case, then can I firstly take this opportunity of thanking you, you both, for taking me back down most of my time in the NHS, both as a nurse, a manager, now a governor, but equally as a patient. And I remember clearly those days in the mid-70s when the sword of Damocles over somebody was there for cancer, and how it's evolved so greatly. From a personal perspective, I was diagnosed with stage 4 lymphoma in, I don't know which year it was, but I've got somebody behind me here who will tell me, who lived through that with me, because that's my wife, and that was in 2012, and I'm still here from stage 4. And I have to thank the good old-fashioned monoclonal antibodies called rituximab, because that was the bit that I think kept me going. So it's something that has taken me, reminded me back of the pathway which some of us just get too used to seeing managed. So that's, thank you for reminding me of that, and thank you for your time and effort to remind all of us how important it is that the cancer services are supported also so greatly by Macmillan. Does anybody would like to say anything to more what I got said? I've got a little things I should have said at the beginning. I've got a list I better say at the end. Is there anybody want to put the hand up? No? Okay. So firstly, thank you, or secondly, thank you for all your time and your effort and the interest there. Can I also take this opportunity to remind people that there are further of these type sessions planned. There is, I've got to take my glasses off so I can read these now. They got as a hospital at home session in September on the 23rd on 2 p.m. There's heart attacks and risk reduction on the 6th of October at 5:30 p.m. Obviously later in the day for that one. So no nipping off to the pub. Vaccination and infection prevention and control on the 8th of October. Keeping moving and staying safe at home. And another one planned is pressure prevention. I presume that's all about tissue viability and pressure sores, but I may be wrong. And then the symptoms and treatments of long COVID as well. Well, to be confirmed. So there, look out for those, the flyers and everything about those being organised. Okay, so I'm now going to refer to my other namesake, Verity. Is there anything I've missed?
Just to say the meeting slides can be requested if anybody
Oh,
wants
yes.
to have a copy.
And there's a video of us all. Oh, yes. Mr. Flaxman.
I'd just like the slides, please. That's all.
You don't want my picture? You don't want my picture?
I would like the slides.
I don't need the video, thank you.
Yeah, I prefer the
Just
slides.
just the slides.
Yes, yes, please.
Oh, I thought I'd be famous.
Almost famous.
Oh, yeah. Life's an almost always, isn't it? Okay. Okay, well, if that's it, thank you very much, everybody. I hope you've gained a lot of information. It certainly was took me down the road of memory for both myself and my carer, my wife. And no, Mike's not flushing. Right, so can I wish everybody to have a very pleasant remaining part of the day?
Yeah. Thank you very
Thank you,
much.
everyone.